Hello and welcome to the latest episode of What's New in Literature in the World of Tracheostomies and Laryngectomies. My name's Mahesh and I'm one of the guest editors for the NTSP. Here at the NTSP, we've been looking at the internationally recognised journals and media to bring you the highlights and discuss the top papers for February 2023. You can find links to the podcast on the NTSP website. You can also search for the NTSP on your favourite podcast platforms, as well as being available on the NTSP YouTube channel. Please do like and subscribe to keep up to date. You can find all of our social media on our website, tracheostomy.org.uk. So in today's episode, there are a few papers that we wanted to highlight. All of the papers will be linked on our website, so let's delve into them. The first paper that I wanted to discuss is a paper titled Salvage versus Primary Total Laryngectomy in Patients with Locally Advanced Laryngeal or Hypopharyngeal Carcinoma, Oncologic Outcomes and Their Predictive Factors. This is authored by a team based in Nice, France. So this study aimed to compare survival outcomes between salvage and primary total laryngectomy patients with locally advanced laryngeal or hypopharyngeal carcinoma and identify predictive factors influencing outcomes. A retrospective analysis of 234 patients was carried out of those who had underwent total laryngectomy between the years 2000 and 2020. So they were categorised into primary and salvage total laryngectomy groups. Later, survival rates including overall survival, cause-specific survival and recurrence-free survival were compared between the groups. A multivariate analysis was performed to identify independent predictors of survival. So the results of this study revealed significantly lower 5-year overall survival, cause-specific survival and recurrence-free survival in the salvage total laryngectomy group as compared to the primary total laryngectomy group. Factors independently associated with poorer survival outcomes included salvage total laryngectomy, hypopharyngeal tumour site, ASA score of greater than or equal to 3, end staging of greater than or equal to 2A, and positive surgical margins. So the study underscores the importance of careful patient selection for larynx preservation protocols and the consideration of predictive factors in therapeutic decision making, particularly for salvage total laryngectomy patients with poor prognosis. The findings suggest the need for further research to explore functional outcomes and compare different larynx preservation approaches to optimise patient care. So the second paper that I wanted to discuss was a paper titled Tracheoarterial Fistula in a Patient with Amyotrophic Lateral Sclerosis Successfully Managed by Overinflation of the Tracheostomy Tube Cuff Alone, a Case Report. So this was carried out at the University of Tsukuba in Japan. From here on, I'll refer to tracheoarterial fistula as TAF and amyotrophic lateral sclerosis as ALS. So, TAF is the most devastating complication after tracheostomy, and its mortality without definitive treatment approaches nearly 100%. So in general, the combination of bedside emergency management, so that is the overinflation of the tracheostomy tube cuff, and definitive treatment such as surgical or endovascular intervention is necessary to prevent the poor outcome. Patients with neuromuscular diseases such as ALS are susceptible to TAF because of the long-term mechanical ventilation and muscle weakness. So this case report describes a 39-year-old Japanese woman with ALS who developed TAF after 7 years of mechanical ventilation through a tracheostomy tube. TAF is a severe condition with a high mortality rate and usually requires immediate surgical or endovascular intervention. However, in this case, the patient's massive bleeding was successfully controlled solely by overinflating the tracheostomy tube cuff without the need for this surgical or endovascular definitive treatment. This case highlights the potential role of temporary overinflation of the tracheostomy tube cuff as both an emergency measure and a final treatment for TAF, particularly in cases where surgical or endovascular intervention is not feasible. It emphasises the importance of early recognition of TAF symptoms, such as tracheal hemorrhage, and in patients with long-term tracheostomy, particularly those with neuromuscular diseases like ALS. Additionally, regular monitoring of cuff pressure and tracheostomy tube alignment is recommended to prevent TAF development in these patients undergoing long-term mechanical ventilation. The third paper that I wanted to discuss is a paper titled Predicting Tracheostomy in Multiple Injured Patients with Severe Thoracic Injury, AIS greater than or equal to 3, with the new T3P score, a multivariable regression prediction analysis. So this was carried out at the University Hospital RWTH in Aachen, Germany. So this was a retrospective cohort study analysing data on patients 18 years or older who were admitted to one of the 6 participating trauma centres with multiple injuries. This study was part of a larger research project with the aim of improving the treatment of patients with multiple injuries with thoracic trauma. So the study aimed to identify predictors of tracheostomy in patients with severe thoracic trauma and develop a prediction score for clinical use. It involved analysing data from 1,019 adult patients admitted to 6 academic trauma centres between 2010 and 2014. Key findings include pre-hospital endotracheal intubation, pneumonia diagnosis during the ICU stay, duration of mechanical ventilation, and severe head injury, all being associated with an increased risk of tracheostomy. One thing that the paper found was, surprisingly, patients with sepsis had a lower risk of tracheostomy. So they developed the tracheostomy in thoracic trauma prediction score, the T3P score. This showed high predictive validity and further validation in external datasets and investigations into reasons for the lower risk of tracheostomy in sepsis patients are recommended. Next paper that I wanted to discuss is a paper called Nomogram and Risk Calculator for Postoperative Tracheostomy After Heart Valve Surgery. So this was carried out at the Renmin Hospital of Wuhan University in China. So this study focused on identifying risk factors and developing a predictive model for postoperative tracheostomies after heart valve surgery. So analysing data from 3,853 adult patients undergoing heart valve surgery, a multivariate analysis found that older age, diabetes mellitus, pulmonary edema, combined aortic surgery, and more intraoperative transfusions of red blood cells were significant risk factors for postoperative tracheostomies after heart valve surgery. So a nomogram and an internet-based risk calculator were developed based on these risk factors. So this demonstrated excellent discrimination, calibration, and clinical utility. So the internet-based risk calculator had 3 risk groups: low risk, medium risk, and high risk, to facilitate clinical application. And patients with postoperative tracheostomies had higher rates of in-hospital mortality, ICU readmission, and longer ICU and hospital stays compared to those without postoperative tracheostomies. So this study contributes to early risk assessment and perioperative management for patients undergoing heart valve surgery, providing clinicians with valuable tools to identify high-risk patients and potentially improve outcomes. The 5th paper that I wanted to discuss is a paper called Contemporary Outcomes of Tracheostomy in Patients with Single Ventricle Heart Lesions. This was carried out at the University of Michigan in the USA. So the study retrospectively reviewed 25 patients with single ventricle heart disease who underwent tracheostomy over a 20-year period. So some of the indications for tracheostomy included various issues such as tracheobronchomalacia, vocal cord paralysis, and tracheal or subglottic stenosis, among others. Survival rates at 6 months were 76%, at 1 year 68%, at 5 years 63%, and 10 years 49%. Most patients completed Fontan palliation at 64%, and patients who underwent tracheostomy for suboptimal hemodynamics and or respiratory insufficiency had a higher mortality risk compared to those with indications of upper airway obstruction or diaphragm paralysis. The findings suggest that mortality risk varies according to tracheostomy, indication in patients with single ventricle heart disease, and tracheostomy may allow staged surgical palliation to proceed with acceptable risk if indicated for anatomic or functional airway dysfunction. The final paper, and a very interesting one, is one that's titled A Novel Approach to Repair of Tracheal Occlusion Secondary to Percutaneous Tracheostomy Creation. So this was carried out at the Medical College of Wisconsin in Milwaukee, USA. So this study presents a novel approach to managing tracheal occlusion following percutaneous tracheostomy creation, particularly in the context of COVID-19 associated respiratory failure during the pandemic. The patient who developed complete laryngeal occlusion proximal to the first tracheal ring underwent a unique repair technique due to the unavailability of the NDYAG laser. So the procedure that this patient underwent instead involved retrograde dilation through the existing tracheostomy site using a Cook-Chiaglia Blue Rhino tracheostomy kit, followed by a Montgomery safe T-tube. This approach allowed the patient to regain tracheal continuity and the ability to speak, with successful outcomes immediately post-surgery. The study highlights the challenges posed by laryngotracheal injuries in patients undergoing prolonged mechanical ventilation, particularly during the COVID-19 pandemic. The described technique offers a simple, cost-effective, and safe alternative for managing occlusions, potentially benefiting centres with limited access to advanced endoscopic instruments or expertise in tracheal surgery. While it may serve as a temporary solution for some patients, it provides short-term relief and palliation, especially for those who may not tolerate more extensive surgical interventions. So that's it for this episode. Please note that the comments and opinions of the authors are our own opinions, and they do not reflect the opinions of any organisations that the authors or our guests work for. Please leave any comments on the website or via Twitter or YouTube. Thank you for listening, and we look forward to seeing you soon.